Well, welcome everyone to our first Chancellor's Town Hall for our alumni and donors. I just want to welcome everybody and tell you how much we all miss you. This is a new world we're all in and doing our alumni engagement virtually. I was in preparing tonight to host this event. It's a busy time of year for us in the development office and the alumni office with a lot of fundraising efforts and things going on. And sometimes you don't stop and take a break. You're so busy this time of year. And as I was thinking about this evening, I started thinking about what it is I'm missing about seeing all of you and seeing everyone. It kind of boiled down to two things, and it was pretty simple. They both started with the letter H, and they were handshakes and hugs. And I got to tell you, I can't tell you how much I look forward to the days of seeing everyone face to face and shaking hands and embracing each other like we've gotten so used to doing with all of our alumni over the years at our events. But we knew that we couldn't stop, that we needed to continue engaging with our alumni. And in some ways, this whole virtual world has broadened our engagement with our alumni. This virtual world we hosted an event a couple weeks ago, and we had people from South Korea joining our event, and that was a first for us, that we had anyone from South Korea at one of our alumni events. So we are finding the silver lining, if you will, in some of these activities. So again, welcome to tonight's event. A little bit of housekeeping. I do just want to say we will be using the Q&A option, or the Q&A feature of Zoom. So if you do have a question, please put it in the Q&A option or Q&A feature. I will do my darndest to try to address those all and at the appropriate time throughout the evening. If I'm not able to address those throughout the evening, we'll do a follow-up. I'll provide my email information here as well, and someone could drop me an email. And if it's a message for the Chancellor or either any of our distinguished guests, speakers tonight, I'll be happy to send that to them and get an answer for you as well. So with that, I want to introduce our Chancellor of the University of Michigan-Flint. Chancellor Deba Dutta joined us just over a year ago here at U of M Flint. The Chancellor comes from us with a distinguished resume from around the Big Ten. He jokes that he's done a tour of the Big Ten over the years. Starting at the University of Michigan as a faculty member in the College of Engineering, moving on to the University of Illinois Urbana-Champaign as the Associate Provost and Dean of the Graduate College there. He then went on to be the Provost and the Chief Diversity Officer at Purdue. And then finally, before coming to us, he was the Chancellor at Rutgers University, where he is described and was described by the faculty there as a model of shared governance between faculty and the administration. And so with that, I'd like to introduce Chancellor Dutta.
Thank you, Brent, and welcome everyone. The way Brent described my tour of the Big Ten, and given how football is going here, sometimes I wonder if this was the right stop, but things will turn around. So welcome everyone. It is really a pleasure to have you join us. We have a good crowd, and I thank Brent and the College of Health Sciences for inviting me to meet with you, although we are doing this virtually. But these are very important in the times that we are, stressful as they are. Every opportunity we get to meet up virtually, share stories, share experiences, and the stresses that all of us are going through. So let me give you a quick update on how the campus is doing in the pandemic. I think we are doing quite well. It's to be taken with a grain of salt. Every day we get news about how things are spiking up in the state of Michigan, in Flint, and on campus too. So, but I think when we switched to online or remote, as we call it, back March 16th, I have to say that our faculty were amazing. I mean, they were able to flip from their on-campus classes to online or remote, some hybrid, in such a short period of time. I mean, I am amazed. And I'm very thankful for their commitment to our students, their well-being, and their educational experience. You probably know this, amongst the three campuses of the University of Michigan. I think I can say that U of M Flint already had a robust online presence. And because of that, our faculty actually were able to do a lot of things fairly seamlessly. And all of this is to say that the students benefited. However, whatever they did, and they are continuing to do, it is putting a lot of stress on them, and a lot of stress on our students. So we are dealing with it as best as we can. But every once in a while, I remind myself and my colleagues that we are not alone in this. Higher education is going through, all of us in Ann Arbor, Dearborn, and any other institution. We are all going through the same thing. Um, so, but we do the best we can. Our classes, just so you know, the fall semester, um, we had originally planned that tomorrow, Friday, November 20th, would be the last day of in-person classes. So this semester we have about anywhere from 12 to 15% on-campus classes, and the rest is remote. So for those 12 to 15%, the plan was that it will end almost today. We have very few classes on Fridays. And after this, the students will be fully remote. So classes will resume after Thanksgiving, but in a remote operation. Exams will happen and so forth. Also seeking the public health guidance that we receive from the state and from Ann Arbor and everywhere. We have a delayed start to the winter semester, and we have removed the spring break. So we're going all the way through. And this does add a lot of stress on faculty and students, but we had to do it. Other campuses were also doing the same thing. So we delay the start in the hopes that the students will not only get a chance to rest, but whenever they come back for that many on-campus classes, they will have the opportunity to isolate themselves, quarantine themselves, and be very safe when they come back to the residence halls. However, the plan so far for the winter semester is indeed the same, about 10 to 12, 10 to 12% on campus and the rest remote. But we'll see if things do not improve, as happened earlier this week with the governor's order, then we'll have to make some changes. But we are still hoping that things will have abated a little bit, and our plans to do the 10 to 12% on campus will be how we will start the winter semester. So the good news is online is fairly robust at Flint. It is getting better. Faculty are doing well, although they are stressed out. Um, However, let's move to a few other updates that you might be interested in. The budget situation for U of M Flint remains, well, it remains somewhat of a difficult situation because of the decline in the enrollment due to the pandemic. We faced, like every other institution, a much more severe decline, and that means less tuition. The good side was the state left us flat. So we did not take a hit on the state appropriations. We had planned for this. So when the fall began, we were able to handle it and move right on. I'm hoping that next year will be better. The worst of the pandemic will have been over. So we will look for increase in enrollment and maybe even state appropriations, who knows? So that's where we are on the budget situation. But I want to give you two updates. Through all this stress and pandemic, I have to say that our faculty and staff are rising to the challenge. We have launched a new college, the 6th college of the University of Michigan-Flint. It's the College of Innovation and Technology. It's the second College of Technology in the state of Michigan, where the college itself is fully dedicated to technology degrees. And technology degrees is more applied than engineering. It is 4-year degrees. They are more than the associates and vocational training, but they are less math and science, more hands-on than the traditional Bachelor of Science in Engineering. So it fits very well with the applied nature of U of M Flint. And we are aggressively moving forward. We hope to admit the first class next fall. Even with the pandemic on, we are moving forward. So I'm very optimistic that the enrollment will increase. The second important item I want to share with you is, given what the country went through and is still going through with systemic racism and the issues that surrounds that, the University of Michigan as a whole, all 3 campuses have taken this on very seriously. At Flint, we have a very vibrant, a diversity, equity, and inclusion program. And through that program, we have now launched the first institute, a campus-wide institute. We have, it's called the Urban Institute for Race, Economic, and Environmental Justice. This is a very appropriate institute for the U of M Flint to have in the city of Flint. It will help us address issues of race, health, environment, and economic concerns. So it is a new institute. It is funded out of the Chancellor's office. We are looking to write proposals and secure external funds. And I'm quite sure that the faculty who are engaged in this will be successful. And once we have the external funds, then I expect new research, new courses, new opportunities for students, and most importantly, for U of M Flint to engage with the community of Flint. So let me stop here by thanking you for remaining engaged as alums and keeping us in your thoughts as much as we are keeping you in our thoughts. And thank you for attending.
Well, it doesn't look like we've got quite any questions yet in the Q&A. So folks do, that is available. So if you have questions for the Chancellor, please be sure to input them in the Q&A option on the Zoom screen there. And we'll get to those a little bit later here where we've got some time set aside for Q&A. So, and I have to say, it's amazing to me to think, Chancellor, you and I, it was days before we closed campus. You and I were in Washington, D.C., likely with some of our guests that are on here tonight. And we were flying out of Washington, D.C. as COVID-19 was setting in and travel restrictions. And I was sort of hoping we were going to get home, I'll be honest. But I remember at that time you talking about the really still, even at that time, still a bit of a concept of the College of Innovation and Technology. And here we are, right? It is launched, it is done. And to me, as someone that has worked at the university for many, many years, applaud you and the faculty and the administration for advancing something like that so quickly. I think that's a testament to the leadership that you've brought to the university, and thank you.
And I just want to take the opportunity to thank Charles Stewart Mott Foundation for the generous grant that allowed us to launch this college. So we are very grateful to them.
Yeah, absolutely. So, one of the other things in hosting these and launching these town halls, we know we don't have research to back this up, but it's the thing that we know from working with our alumni long enough, that they are dedicated and most connected to their college, their school, and their faculty. And so as we launch these town halls, we knew it was important that we engaged with the deans and the schools and colleges and the faculty of those schools and colleges in these town halls. And so we will be hosting one of these town halls with each of the 5, maybe 6, when we get that particular dean in place. Although I know Chris has been appointed. One of our current faculty has been appointed to that deanship. Well, we're down one in School of Nursing, so we're still waiting for our School of Nursing dean. But we soon will be hosting one of these town halls, engaging with each one of our schools and colleges. But we started with the College of Health Sciences tonight, and with us we have Dean Donna Fry from the College of Health Sciences to give us a little bit of an update on the college. Donna holds a BS in physical therapy from the University of Michigan in Ann Arbor, as well as a PhD in kinesiology and exercise science from Ann Arbor. Donna came to the deanship through the ranks of the UM-Flint faculty, holding a position as a faculty member, the director of the PT program, and then ultimately to the dean's office, where she has really seen a transformation of the College of Health Sciences. I remember Donna sitting in your office a couple of years ago talking about the transition to go from a school to a college, to sort of reflect the sort of comprehensive and interdisciplinary nature of health sciences, and the dean has really ushered that change in. So we want to hear an update on the College of Health Sciences.
Thank you, Brent, and I'm very happy to give an update. And I thank you all for joining us this evening. I know time is precious, and I thank you for giving your time to us. And so I'm going to keep my comments and update brief because I know some of you are here to hear the topic for today. But I want to reiterate the Chancellor's comments about how amazing our faculty have been. And I hope that if you know your faculty are still in touch with them, that you reach out to them, because they've really dedicated themselves to providing an excellent experience for students in this trying time. And I know that I personally appreciate all that they do so very much. And I want to thank you out in the audience, those of you who have given of your time and efforts to our programs. You've provided internships and clinical rotations. You've come and taught in our classes, and you do so much for us. And I thank you for your ongoing support of our programs. By way of update on our programs, I'm very happy to say that we are in our 2nd year of our new occupational therapy doctoral program. The students have been doing stellar in that program, and it's exciting to see it launch. And we are also very excited that starting in January, our new Master of Physician Assistant program will begin. We got provisional accreditation just over 2 weeks ago, and we already have a full class starting in January with 40 students. And we got top-notch students who applied to that program, so it was very easy for us to make those decisions. So we're excited to see that launch. We're also proposing right now a new type of master's degree. When our chancellor came, he challenged us to think more broadly about how education is delivered. And we decided to create a stackable degree, which means that we're stacking a series of certificates together that the students can select from a series of certificate programs that we're developing, and they can construct their own degree. They'll be required to take 3 certificates and then a capstone course that will tie it together, and that will form their master's degree. And so that's in development right now, and we are reaching out to industry partners in the health industry to get input on what those certificates may be so that we can best meet industry needs. For instance, next week, I plan to make some phone calls to some of our information officers in our local hospitals to get input and see if we can arrange a meeting so they can guide us in how we develop a new certificate in that area. So if you have any ideas or suggestions along those lines, we would be more than happy to hear from you. And finally, we had an exciting week here, and Dr. Shan Parker was very much a part of that. Our public health programs are seeking their first ever accreditation, and we had an accreditation site visit that I thought went very well. So we're excited to see that happen on our campus. When we were planning for this year, we were planning in the midst of the COVID crisis, in the midst of social turmoil in our country, and in the midst of changing efforts in our community. And we decided we needed to focus our attention on not more than 2 things, because our faculty are already challenged with keeping up with all the COVID changes and transitions. And so we elected this year to modify our pro bono health clinic and how we're running it. Obviously, we had to make changes because of COVID. But we also wanted to make changes to incorporate more of our programs into our pro bono services that we offer because of the expanding nature of our college. But the other thing we decided to focus on is we felt we really needed to address the culture and look at diversity, equity, and inclusion, and specifically address that. It happened that at the time that our leadership in the college was meeting in retreat, that our local county came out with a proclamation that racism is a public health crisis. And so we talked about that and said we can't not respond. We have to do something with that this year. And as we talked about it, we realized, that could be interpreted in so many ways. There's a lot to unpack there. So part of our programming that we're going to do with our students and our faculty this coming winter and spring is to try to unpack. We'll have some speakers in and some conversations and try to unpack the meaning of racism as a public health crisis. So that's one of the things we're doing. We had already been working on revising our admissions processes so they're more holistic. This fall, we're doing a survey of our students to find out what their needs are for learning, the needs for discussion, communication, support around DEI issues. So we're doing that, and I'll also discuss some other things as we get into our talk. So that's an update on our college. And so I'd entertain any questions on that. And maybe while Brent tells me if there are any questions, I will launch our slideshow.
Sure. I'll tell you what, Donna, if you want to go ahead and get going on your slideshow, there's one question that we've gotten that I think is relative to our conversation, so I'm going to hold on to that one. Chancellor, there's one that came up. Dr. Bobby McCummel is on with us tonight and sent a message along, recognizing that sometimes economic downturns like the one that we've had are sort of inversely related to enrollment, right? Sometimes you'll see an increase in enrollment in an economic downturn. I know you've talked a lot about degree completion, that there are millions of people who have some college but haven't completed. Thoughts on sort of opportunities associated with any of that in the current situation?
Yes, I think that is happening. As you read the Chronicle of Higher Education and newspapers, news magazines, that trend is beginning to show up. So we expect that we will also see an uptick in admissions and applications, maybe more in the graduate programs than so much in the undergraduate programs. But yes, we are beginning to see that. I was just speaking with the dean of the School of Management, and he was saying the same thing. So we will know about it in the spring when these applications will come. But I do see this trend across the nation. Yeah, that is true.
Okay. Excellent. Thank you. So we are going to move on. Donna, are you just about set? Excellent. Okay. So joining us tonight with Donna for the presentation is Dr. Shan Parker. Dr. Parker is the director of the Public Health and Health Sciences program, part of the College of Health Sciences. Dr. Parker holds a PhD in health education and health promotion, also has a master's in public health and a BS in biology. Her research interests are in the area of HIV, AIDS, and STDs, as well as diabetes and nutrition education, breast cancer, and cervical cancer prevention. Dr. Parker's work in the area of cultural sensitivity and her expertise in that area has brought her to consult and provide support to many community agencies here in the Flint area. So Dr. Parker, thank you for joining us this evening. And Donna, I'll let you sort of introduce the topic and how it is that you all came to this topic that you wanted to address and head right into your discussion.
Okay. So that's a good question. When I was asked to present something this evening, I thought, well, there are a variety of topics that could have been chosen. And I could have chosen a safe topic. Instead, I thought in the true Michigan tradition of being at the forefront of discussion and sometimes taking risk, that I would choose a difficult topic. This is a difficult topic for many of us to discuss. And I recruited Shan to assist with this because she has much more expertise in this area than I do. But I think we can't not talk about the issues of today and how they affect our health. So let's begin with a story. Imagine Jerome, and that Jerome comes to see you seeking your professional assistance, whether you're a clinician, a public health professional, whatever your assistance that you provide in the health arena. Jerome is 23 years old. He's an African-American male. He has wounds on his chest, back, face, and arms. What are your thoughts? What's going through your head about Jerome? Is this gang related? Is he an illicit drug user? Is he HIV positive? Will he follow a treatment plan? Did any of these thoughts occur to you? They may have. Alternatively, did you think of anything like this? Did he fall down the stairs? Maybe he was taking care of his young child and accidentally tripped and fell down the stairs. Was he in an automobile accident? Did he get in a biking accident when out on his mountain bike? I think the first slide that I showed about Jerome might be more where your thoughts went. And Shan will share a story about this when we were practicing this talk, and I'll let her follow up on that later. So that was an example of how age or racism may enter our minds. Ageism is just another example. I used to teach gerontology or geriatrics in physical therapy. And I remember reading a study once about physicians and comparing the age at which a physician thought they would die, they themselves would die, and comparing that to how aggressive they were in treatment of patients who were older. What do you think the result was? Of course, if the physician thought that they would die at a younger age, they were not as aggressive in treating older patients. And if they felt that they themselves would live a longer life, then they were more aggressive in treating older patients. Now, I'm entering my 7th decade of life, and that's concerning to me, because I bet that's still going on today. So that's an example of ageism and how it can affect people's health. So why are we talking about this tonight? As health professionals, most of us chose these fields because we want to help others. Our decisions came from our hearts, right? We entered these fields out of a true meaning and to find meaning in life and to serve others. I don't think any of us thought when we entered health fields that we're only going to serve people who are old, only going to serve people who are white, only going to serve people who are Christian. We entered our fields thinking we would serve everyone. And I don't think any of us would intentionally treat our patients with anything but utmost respect, irrespective of their age, their race, their religion, their gender identity. I don't think we would do that intentionally. We come to serve people. So how does this happen? I'm going to turn this over to Shan to explain.
Okay, so good evening, everybody. So before we can even really have this discussion, let's kind of really talk about what these terms mean. So what are we talking about? What is this definition of intersectionality? So what is this concept? So Oxford says that intersectionality is this interconnected nature of these social categories, such as race, such as class and gender, and as they apply to a given individual or group, is regarded as creating this overlapping and interdependent systems of discrimination or disadvantage. So Kimberly Crenshaw, who is an attorney and law professor at Columbia and UCLA, she coined this term of intersectionality over 30 years ago. And she stated that it's basically this lens or this prism for seeing the way in which various forms of inequality often operate together and exacerbate each other. So we tend to talk about race inequality as separate from inequality based on gender, class, sexuality, or immigrant status. So what's missing, though, is that some people are subject to all of these, and the experience is not just a sum of its parts. So when you think about this whole concept of intersectionality, it is the merging or the intersection of marginalized identities. And when these already marginalized identities intersect, the likelihood of discrimination and oppression increases significantly. So it's is really focused on how our lived experiences intersect and connect us to these structural systems that lead to oppression. So it's not just all of the identities that make me who I am. It's really how those identities come together that keep me oppressed. So the next slide, Donna. So isms, you can go ahead, click for me. I got some transitions here. Click the, yeah, all right. So prejudice against or in favor of people belonging to a particular fill in the blank. Next click. Prejudice or discrimination or antagonism directed against a person or people on the basis of their, you can fill in the blank, right? So you can, yes, thank you. So we can take this simple statement and fill in the blank with any characteristic or attribute. The point here is that there is a level of disadvantaging an individual or a group based on some attribute. And what we also know is that these isms, they do not exist in a vacuum. They can combine with each other, they can mitigate each other, and sometimes they contradict each other. So these social constructs, list gender identity, religious identity, poverty, educational level, your environment, because place matters, where you live matters, as well as these other social determinants of health, they impact the isms in our world. So I want to just say this, we have to go beyond these single isms and consider all of the intersections of identity, privilege, and oppression that people face, right? And those impacts on their lived experiences, including those experiences in healthcare. So we couldn't have this conversation though, without talking about implicit bias and microaggressions. So now you can go to the next slide. So really this is getting to microaggressions. I'm leaving this here as I start to hold this conversation or go into this next session, because I want you to look at this particular slide. So in society, we have developed ideas and associations based on our lived experiences, our exposures to our families, to our coworkers, our religious beliefs, media, social messages. All of these things are around us, right? So all of these characteristics are around us. But there are these unconscious learned ideologies that we possess. For example, we associate peanut butter and jelly. So nobody ever asked for a peanut butter and cheese sandwich. So we associate salt and pepper. So we never ask for a combination of salt and sugar. So real or imagined, these associations come from some contextual framework. You can go to the next slide, Donna. So we tend to hold these implicit biases that favor our own group. But we know that from research, it's been demonstrated that people can show implicit bias against those who are part of their own group or the groups with which they identify. So we come to the table with implicit bias. Social messages are hard to escape, even for a marginalized group. So Donna said to you earlier, that there's this story that goes along with this. When we were discussing what we wanted to discuss with all of you tonight, she had two stories that she wanted to lead with. So we were going through the stories. So after I listened, I said to her, I said, Donna, let's go for the story about the African-American male and the gunshot wound. So she stopped. She says, wait a minute, I never said it was a gunshot wound. And I said, you're absolutely right. That is the story to tell, because here I am coming to talk to all of you tonight about implicit bias. And I'm going to talk about microaggressions and all of these isms. And I came to the table with my own biases, right? So we've been conditioned to associate African-American males, in this particular case, with gun violence. So that's what I'm trying to say. Implicit biases are very pervasive. Everyone possesses them, even those people who are committed to social justice and being fair and just with all groups, right? So that was just very telling that we come to this whole table with our own biases. So now I have to talk a little bit about microaggressions. And what happens with implicit bias is that it leads to microaggressions. And microaggressions stem from those unconscious learned ideologies that we have. So they help us move this discussion to how various forms of oppression can infiltrate our thoughts. They can infiltrate our behaviors, even when we explicitly value diversity, inclusion, and belonging. So these microaggressions are a result of these systemic isms that we're going to talk about. So you see here that on the slide, I said that implicit bias or unconscious bias leads to these microaggressions. And microaggressions, and I'm going to move on very quickly here, are just these small daily insults and indignities that are perpetrated against a marginalized group or oppressed people. So it's that constant reminder that a person doesn't necessarily belong. And remember that microaggressions can sometimes be intentional, but most of the time they happen on what we phrase as good intentions. So they manifest themselves in lots of different ways, but probably what's more common to us is when people are making remarks, remarks that are obnoxious, that are sexist, that are racist, that are offensive to marginalized groups. And I'm sure that you've all heard some of these. You don't act gay, or you don't sound Black. How did you get in this position? Implying that you have to be a certain way or you have to sound a certain way. Or you're very pretty for a woman of your size. Looking at this whole idea of issues around weight, right? Or that is so ghetto. Or I can't read today. I'm so dyslexic, getting to people who are disabled. All right. Or you speak well for someone who came from, pick any country you like, right? So what happens is these microaggressions that we experience normalize those isms. So in addition to that, those exposures to those microaggressions have this overall impact on one's mental and physical health. So it's putting someone in a constant state of stress. And that we know has lots of implications for for health. Next slide, Donna. So I put this slide here when we get to this whole idea of intersectionality, isms, and health. And it's just showing you health professionals. So although I'm coming at this from a perspective of the patient, I want you to know that there are impacts on minority healthcare providers, right? It's mistaking the female doctor for the nurse, or mistaking the male nurse for the doctor. It's making the mistake of mistaking the Black doctor for the maintenance worker. It's all these types of things that lead to people being overlooked, undermined, or devalued as a person. So next slide. So now how do all of these relate to health? And I'm going to go through this kind of quickly because I want to make sure that we have a little bit of time to really get into the discussion. And I really just only want to focus on two. We can see this intersectionality with isms in lots of different ways and how it manifests itself in health in lots of different ways. But I want to think about pain management. Did you know that there are differences in how pain is managed based on race? We have several studies that say that says that healthcare providers are more likely to underestimate pain among minority patients versus white patients. And that results in not prescribing the same type or the same amount of medication for those patients, or giving that patient just enough of that pain medicine to get them through the weekend. And that speaks to what we've started to associate with addiction, people being at high risk for addiction. And yes, I know we have an opioid problem. Yes, we do. The problem comes when we're not treating patients the same, or our treatments are not the same. So if we're going to reduce opioids, we have to be doing the same thing for all populations. Okay. I want to talk about one more of these because there are a couple of other things I want to say before we get to the Q&A. It's this idea of patient noncompliance, right? Sometimes we as health professionals can perceive our patients as being lazy and not interested in their health. For example, if we're talking about making sure that someone is eating healthy to control their diabetes, to control their hypertension, that they're getting in their physical activity to help manage with these healthcare issues. Well, the reality is we have to listen to what's going on in that person's life, take in consideration all of those factors that are going to influence their health. So if you're talking about someone who has food insecurities, or if you're talking about someone who's living in a food desert, well, the reality is if you're on a fixed budget, it is much cheaper to eat canned goods. Or if you're not in a community where you have enough green space, right, you're not able to get into that physical activity to help yourself. Another area that really gets to this whole idea is that we think that the patient isn't taking their medication. However, it may be that they're unable to afford that medication, and maybe they're taking a half dose. Another structural barrier that I want to talk about is this whole concept of patients being late for appointments, and just thinking about what that means. I know that there are a lot of practices that have policies in place that if you miss that appointment or if you're late, then we're not going to see you. Well, we have to take into account some things that may be happening with that particular individual. Did they have transportation to get there? Are they relying very heavily on someone else to get them there? Because if that's the case and they've had to struggle to get there and they're late, we never take in consideration that they actually did make it. Or if they missed that appointment because there are so many other barriers that come into place that they're not able to get there, and we're charging them a fee. So if you're poor, $25 or $30 makes a big difference in your food budget, right? So that's just a couple of examples that I want to talk about, but I'm hoping that as we are engaged in our conversation, that I get to bring in some more of these examples. So next slide, you got me, great. So what do we do? Oh, I'm sorry. Hold on just a sec. So when we talk about healthcare microaggressions, what we need to know is that they're undermining that patient-centered care that we so desperately want to see for our patients, right? It threatens those opportunities for positive relationships to take place between that patient and provider. And it's devaluing or marginalizing people. That compounds the lack of trust in the medical system. So people don't come back. They don't get the care that they need. And that widens the gaps in health disparities. So what do? That's where we are. I think it's the next slide, right? So what are we going to do? We have to, of course, diversify the workforce in terms of underrepresented groups in medicine, or in healthcare, I should say. Sometimes we're going to have to go beyond the whole idea of cultural competency and cultural humility to look at this whole concept of intersectionality and its impact on health. And we've got to train the next generation of healthcare providers in addressing these concerns, holding people accountable. Even those folks who've been in this profession for years, we've got to make the change. So we've got to be the change. And I am so excited that we are going to have this Urban Institute for Race and Economic Justice, because for us here on our campus, we are clearly dedicated and committed to looking at diversity, equity, and inclusion, and really making sure that we're going to have an impact on our community. So that's what we do. So I'm going to turn it over to Donna, and she'll go from there.
Okay, and so I have just a few slides in conclusion, building on Shan's portion of the talk. And when we look at how to respond to this, we really have to go back to our values. And these are values that were developed by our faculty for our college: excellence, diversity, student-centeredness, integrity, community engagement, and social justice. And in having those in the background and looking at our planning for this year, we decided we needed to do something not only for our students, but for the faculty. In looking at our diversity, equity, and inclusion efforts, we thought that the first thing we need to do is educate ourselves. And so we are planning a series of sessions with our faculty to learn more about implicit bias and the microaggressions that Shan was talking about. We were talking about including this in our curriculum, but we realized first we need to look at ourselves and learn more so that we can be better educated on this, so that when we go to discuss it in how we might enter that into our curriculum in a better way, that we would be more educated in doing so. We're devoting our May retreat to this topic in terms of how we may introduce more of this into our curriculum. Our students are asking for this. They want to see more of this in the curriculum than they get. We want to introduce more of it into the curriculum and would love it to carry forward into their clinical internships and clinical rotations so that we can translate that into clinical practice. So I invite you in the coming year to join us in this journey. We will be learning about cultures other than our own. We will be reflecting on our own beliefs and possible biases. We will try to grow in respect for others. We will strive for better health, not only for the individuals we treat, but better health for our communities through policy reform, insurance reform, etc. So we need to work on this ourselves, and we ask you to join us in the journey. We will have some public events coming up in the winter semester when we begin to schedule out our programming around racism as a public health crisis. And so we'll make sure we get the word out about those events so that you may be able to join us. They'll be virtual. So this is our Q&A time. And in the true tradition of an educator, I wanted to pose some questions to trigger you for the Q&A. So we would love to hear what is happening in your workplace around these issues. And we would love to hear your suggestions on how we may incorporate this into our respective curricula. And we would dearly love to have you help us with some case examples that we could use in teaching. And so I invite your questions for Shan, for myself, for Chancellor Dutta. And I also shared Shan's and my email address so that if you don't feel comfortable, some of these topics are very uncomfortable to talk about. If you just want to share something with us personally, I invite you to do that. Or if you have information you want to share, please contact us by email or reach out to us by phone, whatever method you choose. So I invite your comments and questions.
So Donna, we had a question that was submitted around the role that educating our health professions folks plays in addressing this issue of isms, and then the individual said, "Oh, they already answered my question because you guys got to it." But there was a piece of Elizabeth's question where she asked it sort of, does the responsibility lie in us educating our health professions folks, or does the responsibility lie in the consumer and in the role of health services? And I don't know that it's an or, it's probably an and I'm curious about the role that the consumer plays in addressing these issues of isms in healthcare.
I'll respond, and then I'm sure Shan has a better response. I'm a physical therapist. If I am not learning from my patients, I'm not a good physical therapist. And so I think we always, no matter what it is, whether it's one of these isms, I worked with a lot of people who had various disabilities. I have learned so much from them about how to treat people with respect. And so we do learn from our patients. But Shan, I'm sure you have other comments to share as well.
Well, I would agree with that. I think it's listening to your patients. They're going to tell you exactly what they need, but it's not listening and giving them exactly what you think what you think they should have anyway. It's having a conversation, it's having a discussion, and they're going to educate you about what their needs are. It's getting back to that whole concept of intersectionality, right? It's looking at all of those factors that are going to be important, right? It's looking at, their physical environment, it's looking at, excuse me, excuse me, but it's being able to have the conversation that gets to what those patients need. It's not just saying, okay, I heard you, but then doing what you want to do, right? So it's a true discussion, it's a true communication. And then you can't be dismissive. So if the patient tells you that they are experiencing something that may be negative or may interrupt that relationship that you have with them, you can't say, oh, well, that they didn't mean that, or that wasn't what you got to have a real true open-ended conversation. So patient provider communication is key.
Dr. McCullough chimed in with something else here, stating that the governor's mandated implicit bias training for all healthcare professionals, and wondering about the strategic opportunity for the University of Michigan-Flint to offer that sort of University of Michigan brand to give professionals the training that they need to fulfill those requirements. Is that something that the college is talking about, Donna?
We have talked about that, and I think we were preempted by Ann Arbor. My understanding is that Ann Arbor has something ready to roll out because they've been in close conversation with government officials on that. And so we thought if Ann Arbor's already has something prepared and are rolling it out, that it didn't necessarily make sense for us to duplicate that. But we will be promoting that and making sure our folks are using that. And great idea, Bobby.
Chancellor Dutta, Sabita Tumala, one of our alumni and great volunteers over the years, chimed in here and wanted to just ask you to just elaborate a little bit more on the Urban Institute.
Yeah, so the Urban Institute and health. The way Shan described it, and Donna did too. So if you think of the Urban Institute for racial, economic, and environmental justice, at the intersection of race, environment, and economic justice is health, the individual's health. It's a very central part of it, as was described in the previous presentation. However, the Institute is broad in its charter, and we will be looking at all of these three strands individually, and we will be looking at what effects these three have on the individual, on the society, the community. So that's the goal. We will be doing research. There are very rich topics that are at the intersections of two or three, or even embedded in each one of them. So we will be looking at that. But the feature that I am most happy about is that the Institute will be a community-based institute. It is not just U of M Flint faculty and staff and students doing research, but they are doing it with the community, for the community. And that is very powerful, I believe. So at this point, it's just getting started. Jan Furman, a professor emerita of English, is the executive director, and Tom Bell from the College of School of Education is the managing director. And I expect new proposals to come out from this effort. And we have some seed funding. So I'm very hopeful that it will address issues that are germane to this community and create new intellectual products, new knowledge that we can all benefit from.
Brent?
Yeah, wonderful. Oh, we had another, oh boy, we had a big question come in here.
Shan,
Shan, did you have something, Shan? Go ahead.
Yeah, I just wanted to say just one other thing in regards to that first question. I think it's a lot of factors. I think it's definitely working from with the patients. I think we definitely have to have this implicit bias training. We have to start training our healthcare providers, but more importantly than that, we have to start breaking down the structures, right? We have to start breaking down those structural barriers that impact what's going on. And that's going to require having those difficult conversations and holding people accountable for their actions. I just wanted to put that in.
Donna, I've got a long one here from Georgina that doesn't have a question necessarily, but it has a lot of content in terms of what's happening at Marshall University. So I'll be sure to forward that to you all so you can consider that sort of in response to your request for input. One other question we had that I can address is wanting to know if this presentation will be available on demand. The answer is yes, it's been recorded. We will be posting this on the University of Michigan-Flint Alumni Relations website under our University Events tab. Within the next 24 hours, I've got to get the video and we'll get it posted to YouTube and then share it there. So it will be available there. So we are out of time. There are no more questions in the queue. So I thank everyone for being here. Any final remarks from any of our panelists, Chancellor, Donna, or Shan? Any final things you'd like to say?
I really, truly hope this is an ongoing conversation. We really would like to hear from you informally, formally, and we'll be talking about this much more over the coming year and years, most likely.
And from my side, I'd just like to thank everyone for attending this event and make an appeal that please remain engaged. We will do our best. Please remain engaged with the institution and the activities that we are engaged in.
And from the Alumni Relations Office, I would just again like to thank everyone for being part of our first Chancellor Town Hall with alumni and donors. I will declare it a success with 40 or so participants. So very pleased with that. Everyone stay safe. And most importantly, go blue.
Go blue.